Hello friends, welcome to Knowledge Bites. Friends, today I am going to teach you an important chapter of subject ENT. The chapter is rhinitis. Okay, so now broadly classifying rhinitis is of two types: acute rhinitis and chronic rhinitis. Now talking about acute rhinitis, the most common cause of acute rhinitis is viral infection. And which virus? The virus is rhinovirus. Other cause of acute rhinitis. The other cause of acute rhinitis is bacterial infection or and irritants, any irritants which can predispose to acute rhinitis. Now we will see the chronic rhinitis. Okay, the chronic rhinitis are of five types: chronic simple rhinitis, chronic simple rhinitis. Second type is the hypertrophic rhinitis. Third type is the atrophic rhinitis, and fourth type is the rhinitis sicca, and the last one is rhinitis caseosa. So dealing with first type, that is the chronic simple rhinitis. So how this chronic simple rhinitis occur? It occurs when acute rhinitis it gets converted to chronic rhinitis when the infection is prolonged or recurrent. Acute rhinitis gets converted to chronic simple rhinitis when the infection is recurrent or prolonged. So what are the clinical feature of chronic simple rhinitis? The clinical feature are nasal obstruction. Then because of nasal obstruction, headache will occur. Headache. Nasal discharge. Post nasal discharge. Swelling of turbinates. So the clinical feature are nasal obstruction, headache, nasal discharge, post nasal discharge, and swelling of turbinates. So now what is the treatment of chronic simple rhinitis? Since it is occurring because of acute rhinitis, if we treat the cause, then the patient will get relieved. So the treatment of chronic simple rhinitis is treatment of cause plus we give nasal decongestant. Okay, now we will talk about nasal decongestant. Nasal decongestant. The nasal decongestant which we give, they are alpha 1 agonist drugs. The drugs are oxymetazoline, or we can give xylometazoline. These two drugs are the alpha 1 agonist drugs. These drugs are given up till 7 days. Now the question here is, what will happen if we give the alpha 1 agonist drug, that is the oxymetazoline or xylometazoline, for more than 7 days? Okay, so what will happen? Two things will happen, that is the rebound congestion. First is the rebound congestion, and second is the loss of cilia, and squamous metaplasia will occur. Squamous metaplasia will occur. So now what this condition called? This condition is known as rhinitis medicamentosa. Rhinitis medicamentosa. So the question is, what is the meaning of this rebound congestion? Okay, so up till 7 days nasal congestion is relieved, but if we use for more than 7 days, the patient condition gets worse. The question is how? It is because now the patient requires increased dose and frequency to get relieved from the nasal congestion. Okay, so this is the rebound congestion. So here we can see that rhinitis medicamentosa has occurred because of the prolonged use of the alpha 1 agonist drugs. So now we have to treat rhinitis medicamentosa. So the rhinitis medicamentosa is the side effect for the prolonged use of xylometazoline and oxymetazoline. So now the treatment of rhinitis medicamentosa, the treatment is withdrawal of drugs, withdrawal of nasal decongestant, withdrawal of nasal decongestant plus administration of local or systemic steroid. Administration of local or systemic steroids. So now what is the function of this steroid? Since we have given this to the patient, it just modulates the gene transcription. It just modulates the gene transcription and restores the function of alpha 1 receptor. Modulate the gene transcription and restore function of alpha 1 receptor. So now we have completed with the chronic simple rhinitis and the side effect, that is the rhinitis medicamentosa. Now we will see the hypertrophic rhinitis. Hypertrophic rhinitis. So how the hypertrophic rhinitis occur? It occurs due to chronic simple rhinitis. Chronic simple rhinitis will get converted to hypertrophic rhinitis. Then what really happens in the hypertrophic rhinitis? So it is because of repeated infection. Because of repeated infection, mainly submucosal fibrosis occur. Mainly submucosal fibrosis occur. The submucosal fibrosis leads to hypertrophy of nasal terminates. The hypertrophy of nasal terminates has occurred. Middle terminate hypertrophy and most commonly the inferior terminate hypertrophy. Most commonly the inferior terminate hypertrophy. When the inferior terminate hypertrophy occurs, then it gives the appearance of mulberry. So it is the mulberry appearance. So now, what is the treatment of hypertrophic rhinitis? The treatment of hypertrophic rhinitis is, so firstly before the treatment of hypertrophic rhinitis, we will see the clinical feature. The clinical feature of hypertrophic rhinitis. Since the hypertrophy of nasal terminates has occurred, so what will be the most distinguished feature of hypertrophic rhinitis? So the main complaint of patient having hypertrophic rhinitis is the nasal obstruction, since the hypertrophy of nasal terminates has occurred. So now what will be the treatment? So the treatment will be terminectomy. Terminectomy can be partial or total. Okay, so how terminectomy is done? It is done by laser surgery or cryosurgery or by the use of diathermy or by using radio frequency. So now we have completed with the hypertrophic rhinitis. Now we will see the third variety of chronic rhinitis, that is the atrophic rhinitis. With the word atrophic, it is clear that the something atrophy is occurring. Okay, so what happens here? Here chronic inflammation of nose occurs. Because of the chronic inflammation, atrophy of nasal mucosa and terminate occur. Atrophy of nasal mucosa and terminates occur. So it will look like there is very much space in the nose. It will give the appearance of roomy nose. It seems like there is very much space in the nose. Okay, this is a bilateral condition. Atrophic rhinitis is a bilateral condition, but no watery nose. No watery nose. Okay, atrophic rhinitis is of two types. Atrophic rhinitis is of two types, that is the primary and secondary. So firstly we will see the primary atrophic rhinitis. Primary atrophic rhinitis. Etiology. Most commonly it is idiopathic. The cause is not known. Idiopathic. The other cause can be known to you by this mnemonic: hernia. The full form of hernia means this is the mnemonic. So H means heredity, endocrinological disturbance, due to deficiency of hormone estrogen. Race, the people who are white or yellow suffer from this. Nutritional deficiency, such as deficiency of iron, vitamin B12, sorry, not vitamin B12, vitamin A and D. I means infection. Which bacterial infection? The bacteria is Klebsiella ozyna. Therefore, atrophic rhinitis is also known as ozyna, and A means autoimmune. Now we have completed with the primary atrophic rhinitis. Now we will see the secondary atrophic rhinitis. After that we will see the pathology, common pathology in both. Secondary atrophic rhinitis. In secondary atrophic rhinitis, cause are very much known. It is due to the secondary to some of the destructive granulomatous condition of the nose. Secondary to some of the destructive granulomatous condition of the nose, such as leprosy, rhinoscleroma, systemic lupus erythematosus, syphilis. So now what is the pathology behind primary atrophic rhinitis or secondary atrophic rhinitis? Pathology behind the atrophic rhinitis. So everything in the nose get atrophied, means it looks like the nose has become roomy. Okay, here pseudo stratified ciliated columnar epithelium, the metaplasia has occurred and it has changed to stratified squamous epithelium. You can see here the nose looks like empty space, means it has a room, but in spite of roomy cavity the patient has nasal obstruction. So the clinical feature is nasal obstruction. So the question is, why nasal obstruction is occurring? Since the uh, nose is having very much space, it looks like a room type, but still the clinical feature says that it has nasal obstruction. So it is why. So it is because of excessive crusting. The crust formation has occurred, and also because of the loss of sensory nerves. The patient feels like his nose is blocked. Okay, because of the loss of sensory nerve, the patient feels like his sensation of nose is blocked, is felt as blocked. Okay, there is an absence of defense mechanism. So if there is an absence of defense mechanism, because of that very foul smelling discharge occurs. Clinical feature is nasal obstruction, but also the patient has hyposmia, means he has lost the sensation of smell. So you can see here, since there is an absence of defense mechanism, the patient is having very foul smelling discharge, but itself the patient is having hyposmia, means he cannot smell his own foul smell, and that particular thing is known as merciful or blissful anosmia. Hyposmia has occurred, or it can be anosmia also. Anosmia also. Okay, so now what is the medical management? There are two types of management, that is the surgical management or medical management. So now we are talking about the medical management. In medical management, we are giving something which is known as alkaline nasal douche. Alkaline nasal douche. In alkaline nasal douche, sodium chloride, sodium bicarbonate, and sodium borate in 280 ml of distilled water. NaCl, NaCO3, that is the sodium bicarbonate, and sodium borate. They are given in 280 ml of distilled water in ratio of 2:1:1. What is the function of alkaline nasal douche? It removes the crust. Now we are giving 25% glucose in glycerine spray. Some of them may think that we are giving nutrients to the bacteria, but it is not so. Okay, because of seeing 25% glucose, it's not so. Why we are giving 25% glucose? It is because fermentation will occur of glucose, and because of that lactic acid is produced, and this lactic acid will kill the proteolytic bacteria. And then what is the function of glycerine? Glycerine just lubricates the nasal mucosa, and it is hygroscopic. It attracts the water, it attracts the moisture. We are also giving chemicity solution. Chemicity solution. Chemicity solution, it contains the contents can be remembered by the mnemonic of PCOD. P means propylene glycol, C means chloramphenicol antibiotic, O means ostradiol, and D means vitamin D2. We are also giving submucosal placental extract. Submucosal placental extract and ostradiol spray. We are also giving potassium iodide. Now we have seen the medical management of atrophic rhinitis. Now we will see the surgical management. In surgical management, we have to just remember the name, and that is enough. The surgical management are Young's operation, modified Young's operation, Lawton-Slager's operation. Any of the operation can be done in case of atrophic rhinitis. Now we have completed the atrophic rhinitis. Now we will see the fourth type of rhinitis, that is the rhinitis sicca. So in rhinitis sicca, crust formation is seen. Crust formation is occurring, but the cause of formation of crust is seen in patient who lives in hot, dry, dusty environment. It affects anterior one third of nose, particularly nasal septum. The ciliated columnar epithelium changes to squamous epithelium, means metaplasia is occurring. So what is the treatment of rhinitis sicca? The treatment of rhinitis sicca is remove crust. How we can remove crust? By applying alkaline nasal douche, plus also we are giving antibiotics and lubricants, such as we can give glycerine spray. Now the last type of rhinitis, that is the rhinitis caseosa. It is also known as nasal cholesteatoma. It is usually unilateral condition. It affects male more than female. Treatment is scoping the discharge plus treating associated causes. So now we have completed each and every types of rhinitis, but still we are missing two more rhinitis, and they are the allergic rhinitis and vasomotor rhinitis. So now talking about allergic rhinitis. So allergic rhinitis is occurring because of type 1 hypersensitivity reaction. If it is occurring because of type 1 hypersensitivity reaction, then it must be mediated by IgE antibody. So what are the clinical feature? Clinical feature are rhinorrhea, running nose or post nasal drip, nasal obstruction, lacrimation, itching of eyes and nose, Denny Morgan lines. Denny Morgan lines. These are the creases in the lower eyelid. Generally in lower eyelid no crease is present, but in Denny Morgan lines it means that there is a crease in lower eyelid, which is seen in allergic rhinitis. Or puffiness below lower eyelid, puffiness below over eyelid. So investigation, how we are going to investigate the patient? We have to investigate that if the patient is suffering from any type of allergy. So we are doing skin prick test, or we are doing RAST. The RAST is radioallergosorbent test. Radioallergosorbent test. So now, what is the treatment? If we have get to know that the patient is suffering from allergic rhinitis, then what drugs we can give? We can give antihistamine, antihistamine. We can give intranasal steroid. We can give mast cell stabilizer. We can give leukotriene antagonist. There are few drugs which are given in bronchial asthma too. These drugs can be given in bronchial asthma too. Montelukast. Now we have completed the allergic rhinitis. Now lastly we will see the vasomotor rhinitis. Vasomotor rhinitis. It is also known as non-allergic rhinitis. It is also known as intrinsic rhinitis. The symptoms just associate with the allergic rhinitis, but it is not allergic rhinitis. Then how can we differentiate it from allergic rhinitis? We can differentiate it from allergic rhinitis by doing investigation. The investigation which we are doing in allergic rhinitis, that was the skin prick test and the RAST. Skin prick test, or we can do RAST, that is the radio allergosorbent test. The test comes to negative. Okay, so now we can say that it is now vasomotor rhinitis. So how this vasomotor rhinitis is occurring? It is because it is due to parasympathetic nervous system overactivity. Because of the involvement of median nerve. It does the vasodilation and therefore congestion occurs. So the medical management, we are giving nasal decongestant, but remember nasal decongestant are given for less than 7 days, plus we are giving steroids. After giving these, if no result occur, no benefit occur, then we are proceeding to surgical management. So what is the surgical management? We do Vidian neurectomy, that is we are damaging the Vidian nerve. So finally we have completed the rhinitis. Hope so you enjoyed my lecture, and don't forget to subscribe my channel for more upcoming videos. Thank you.